Hello, my dear curious and studious students of surgery. Myself, Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery, anesthesia, radiology with orthopedics with video. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 57, that is the neoplasms of the bladder. In this lecture we will continue the primary neoplasms, secondary tumors of the bladder, carcinoma of the bladder, transitional cell carcinoma of the bladder, the grade and the stages of the tumors of the bladder, squamous cell carcinoma, adenocarcinoma of the bladder, TNM classifications of the carcinoma of the bladder, and total and partial cystectomy. Now start with me the neoplasms of the bladder. The classifications: primary neoplasms and secondary tumors. Primary neoplasms, there are a type epithelial tumors and the connective tissue. In the epithelial tumors, which constitutes more 95% of the cases. Benign tumor, papilloma, either solitary or multiple. Second, malignant tumors like transitional cell carcinoma, either de novo or secondary to papilloma. In the malignant tumor, second is the squamous cell carcinoma and third is the adenocarcinoma. And in the primary neoplasm, the second part is the connective tissue tumors. Angioma, endometrioma, myoma, fibroma, pheochromocytoma, arising from the accessory adrenal tissues in the bladder wall, and malignant sarcoma. Dear students, here is the image which will useful in your next slides. Here is the stages and gradations of the spread and development of the tumors of the bladder. You can see this is the another image showing the stepwise classification of the stage and gradation of the bladder tumors, the lining of the bladder, connective tissues, the muscles and the fat, layers of the bladder wall, the infiltration of the bladder carcinoma according to stage is clearly seen in this image: T1, T2, T3, T4. This is the CT image showing the carcinoma of the bladder. Now the secondary tumors, extension of the malignant neoplasms from a neighbouring organ, particularly sigmoid colon, rectum, uterus or ovary. Sometimes carcinoma of the pelvis colon or rectum first represent with symptoms of cystitis, and cystoscopy reveals an area intense inflammation, which is the first site involved by the carcinomatous lesion. Later on, even a vesicorectal or vesico-intestinal fistula may develop. Papilloma or papillary carcinoma of the pelvis of the kidney may spread to the bladder by seedling implantation. Prostatic carcinoma may involve bladder by the diet spread, but this is a rare occurrence. Now, next point is the carcinoma of the bladder. There are three types of the carcinoma of the bladder. First is the transitional, second is the squamous, and third is the adenocarcinoma. By far, the majority of the 95% is the transitional in origin. Transitional carcinoma. There are two types usually seen. One is the papillary type, second is which is less malignant, and nodular type, which is also known as the invasive type and carries bad prognosis. Dear students, here is the picture of the transitional cell carcinoma of the bladder. You can see on your image, on your screen. This is the another image showing the papillary type of the carcinoma of the bladder, and this is the villous type of the carcinoma of the bladder. This is the image showing the schematic diagram to show the clinical staging of the bladder carcinoma. TIS is the innermost layer. There is a T1 is the villous, T2, T3, T3, T4, T3B, T3AB, T4B, T4A. As the stage is going ahead, the infiltration of the squamous cells or transitional cells being rooted in the bladder wall, and in the last stage, that is the T4, is invaginated in the neighbouring viscera. You can clearly see in this picture. Now the next point is the papillary type of the transitional cell carcinoma. These are the papillary tumors which grows from the bladder mucous membrane. These may be single or multiple at the time of the presentation. The most common sites are on the base of the bladder, about 80% just outside the ureteral orifices. In and around the trigon area, the nodular tumor is more malignant than the papillary type. Then the next is the nodular type. This is the usually solid in consistency which invades the muscle quickly. There may be tufted appearance from outside. These tumors are large and broad base. Sometimes these may be the ulcerated. The incidence of the metastasis is more. Now the grade and the stage of the tumors. Grade first, according to the degree of the cell differentiation, carcinoma of the bladder has been classified into two various grades. Grade first, the cells are well differentiated. The lamina propria is usually not involved. It is papillary in type. It is usually has a narrow base. They are usually curable by transurethral means and are radio resistance. Grade 2, here the cells show the less differentiation and show a tendency to invade the lamina propria but not the detrusor muscle. The tumors are larger than grade 1 tumors and have a wider base. These are also curable by transurethral resection and these are also radio resistant. Grade 3 and 4, these neoplasms are poorly differentiated and anaplastic. This tends to be nodular rather than the papillary. These are quite invasive. These tumors are not good for transurethral resection but are sensitive to radiotherapy. Now, stages 0, that is the TIS. This is a carcinoma in situ or a papillary tumors which has not invaded the lamina propria. Stage A, TIS, the tumor has invaded the lamina propria but not the muscle of the bladder. Stage B1, that is the T2, the tumor has extended into the superficial half of the detrusor muscle. Stage B2 and T2, T3, tumors has invaded the full thickness of the muscles and is mobile. Stage D, that is the T4, the tumor has invaded an adjoining tissues and organ has involved prostate. The tumor has become fixed. Stage D1, that is the N1, the tumor has involved lymph nodes but not above bifurcation of the aorta. Stage D2, that is the M1, the tumor has metastasized to the periaortic lymph nodes and to the distant organs. Now the spread of this carcinoma of the bladder is the spread by the direct spread, lymphatic spread, hematogenous spread, spread by implantation or seedling, allantoic spread. Now the squamous cell carcinoma. About 5% of the vesical neoplasms are of squamous cell variety. Squamous cell tumors are usually solid in consistency and often invade the detrusor muscle. Such carcinoma is seen when the squamous metaplasia or keratinization has occurred. This is often secondary to chronic irritation or stone disease. These tumors are highly malignant, anaplastic, deeply invasive and metastatic easily. This tumor shows high incidence in the patient with vesical bilharziasis. Third is the adenocarcinoma. This constitutes about 1% of the vesical neoplasms. This tumor is also seen as a complication of ectopy of the bladder. The tumor is usually sessile and mucus producing. It usually occurs at an earlier age than transitional cell carcinoma of the bladder. Dear students, here is the typical picture of the adenocarcinoma of the bladder is clearly seen. There is the adenocarcinoma. This is the another picture of the adenocarcinoma, resected adenocarcinoma. Now the clinical features, symptoms, painless hematuria is the earliest and most common symptom. Second is the acute retention of the urine. Third is the pain in the pelvis indicates vesical spread. Now the special investigation is to be done in the bladder cancer, that is the blood examination, urine analysis, cystoscopy, excretory urography, retrograde cystogram, vesical angiography may yield information about the depth of the infiltration of the tumor. Next investigation is the CT scan. The rate of the accuracy is approximately 80%. Ultrasonography, magnetic resonance imaging, that is the MRI, lymphangiography may be performed to exclude the lymphatic metastasis. Accuracy rate is only 50%. Tumor markers and increased level of the urinary or plasma embryonic antigen is found in 60 to 70% of the cases. Urinary immunoglobulins, that is the IgG and IgA, are also elevated. Now the treatment. There is a considerable disagreement about the proper treatment of the vesical neoplasms. Transurethral resection should be performed for low-grade superficial tumors, whereas for more malignant and invasive tumors of the surgeons must choose between the radiotherapy and radical surgery for the combination thereof. The treatment of the being discussed according to the stage of the tumor for proper understanding. For the stage TIS or N0M0 carcinoma in situ, these lesions should be managed conservatively by repeated cystoscopy and excision biopsies of unstable areas, that is the resection biopsy should be taken by the cystoscope. For the second stage, that is the T1 N0M0 tumors, this category now includes all papillary tumors, both non-infiltrating and infiltrating non beyond the submucosa of the bladder, in which biopsies show no evidence of the invasion of the muscles of the bladder. Cystodiathermy or transurethral resection by the cystoscopy is the main treatment. If the tumor is too large, the bladder may be open and the tumor is removed transversically. Care being taken to sussurize deeply into the wall of the bladder in order to remove the base of the tumor completely. Either there is a chances of the perforation of the bladder. This procedure will cure many of the papillary carcinomas of this stage. Intravesical chemotherapy is attractive, is an adjuvant measure or alternative treatment for the bladder which has multiple recurrences at each check cystoscopy. Intravesical epidural has the advantage that it is not absorbed and free from the systemic side effects. 100 ml of 1% solution of the epidural is the sterile water should be introduced for 1 hour once weekly for 12 weeks, then monthly for a year, then 3 monthly for at least for the 7 years. Intravesical chemotherapy is indicated in patients with widespread multiple superficial lesions. And for the stage 3, T2, N0 or N1 and M0 tumors are there, then when the infiltration is confined to the superficial muscle, that is the T2 tumors, endoscopic diathermy alone is inadequate. If the tumor is situated towards the vault of the bladder, partial cystectomy is justified. If the tumors is multiple or too extensive for the local treatment, choices lies between the external beam irradiation, total cystectomy or preoperative irradiation and cystectomy. And for the stage 4, that is the T3, N0 or N1 and M0 tumors, the prognosis of these groups of tumors is extremely grave. The choice lies between the radical cystectomy and the radical radiotherapy, with or without salvage cystectomy. In case of the radical radiotherapy, optimal dose is 6000 rats given over a period of the 6 weeks or more. In case of the preoperative irradiation, a dose of the 2000 to 4000 rats are given, followed by the radical cystectomy and pelvic node dissections. Chemotherapy, the drug used are 5-fluorouracil, methotrexate, adriamycin, cyclophosphamide, cisplatinum. Promising results have been achieved with parenteral cyclophosphamide. CIS platinum and doxorubicin. Doxorubicin is the injected 10 to 20 mg into the tumor 1 to 2 times per week. About 80% success has been claimed. Now the partial cystectomy. This means that the tumors along with the surrounding 1 inch of healthy margins of the bladder wall is dissected in its entire thickness. Not many malignant tumors yield themselves to this operation since many of them are situated near the trigon. Now the total cystectomy. This operation implies removal of the entire bladder together with the seminal vesicles and the prostate. This operation is indicated in case of the infiltrating growth involving internal meatus, both ureteric orifices, profuse papillomatosis, recurrence after adequate radiotherapy, recurrence after partial cystectomy, and for this, after the total cystectomy, the operation of the ileal conduit is to be performed. Dear students, regarding the ileal conduit, I will explain you in the next lectures where there is a necessary. Here is the end of our surgery lecture number 57, that is the neoplasms of the bladder. Thank you.